talk about patellar tendinopathy. My name is Paul TERAN, and I have no conflict of interest to give this conference. We belong to ONLAT, and the objective of this lecture is talk about this important tendon like the patellar tendon. It's a most powerful tendon in the human body, and it's important to remember that the physiological range of elastic capacity of the tendon is around 5%. Over 5% have a chance of generating microscopic damage, but more than 8% of its elastic capacity of the tendon can break. Thus is a first cause. Higher the load, greater probability of damage. But the tendinopathies have a stage of production. In the first level is the injury produced by repetitive activity, previous traumatic injuries, chemical products, or pathologies that damage the tendon. At the next level, in the stage 2, there is a failure in the healing process determined by two large groups of intrinsic or extrinsic factors to reach stage 3, where the clinical manifestations are characterized by pain, weakness, or rupture appears. Here we can see a normal tendon, a microscopic tendon. There are changes in cellular structure in the first stage. The tenocytes become parallel, cell nuclei become rounded, and tenocytes lose their fine shape. This is called fibrocartilaginosus metaplasia. When there are intrinsic factors, such as dyslipidemia, genetic factors, hypermobility, overweight, and too many, or extrinsic factors, such as the use of corticosteroids, statins, previous ligament injuries, consumption of quinolones, or poor sports technique, we move on to phase 2, where the tendon healing process fails. Existing in this stage, we have disorders of tenocytes, proliferation, degeneration of the tendon cells, disruption of the collagen fibers, an increase in non-collagenous matrix. This is now when we reach to phase 3, where the clinical manifestation appear with failure to bear loads and the appearance of pain producing mechanical failure, like this example. Canut et al. Demonstrated the existence of degenerative chains in 97% of Achilles ruptures. But we must not forget that pain, all the pain in the general of tendinopathies, is caused by a complex system of altered neurotransmitters, even at the level of the central nervous system, like increase of glutamate or increase of substance P, the histamine and noradrenaline. The patellar tendinopathy is the second most common tendinopathy. The first one is the Achilles tendinopathy. The patellar tendinopathy is the first cause of pain in the anterior region of the knee in high-performance athletes. Progressive limitation of function appears with a variable pain according to degree of affectation and time of evolution in each tendinopathy, and is difficult to recover with a reserved prognosis in chronic cases. Histological, it's a degenerative process. It's hypoxic, hyaline, mucoid or myxoid, fibrinoid, lipid, calcifying, and with a fibrocartilaginosus metaplasia. All cells in this tendinopathy changed, like collagen, tenocytes, and the extracellular matrix changed the shapes, changed the function. That's the reason, because it's very, very, very important. And the collagen fibers, the collagen fibers are lose their parallel orientation, decrease in diameter and density, and type 3 of collagen increase. failure to perform its function. But on physical examination, the basset maneuver with knee extension is a positive, and the pain might disappear with the knee is in flexion. It's important to evaluate the state of extensor system and the range of mobility with like dynamic gestures like that. It's important to think in a differential diagnosis like Cinder-Larsen-Johansen in younger patients, like Osgood-Slater 2, the patellar chondromalacia, patellar bursitis, medial synovial plica, meniscopathy or rupture, total or partial tear of tendon is very important. And we use the Blasina scale, which is based on the patient's pain when performing physical activities. In the first stage is no pain, and the stage 4 is when the function is totally altered because the tendon rupture secondary to chronic tendinopathy. And also the BIS scales that allow us a clinical classification based on symptoms, severity, functional capacity, and sports performance. As a method of initial diagnosis, ultrasound has shown safety in 12 diagnoses compared to MRI, allowing to see details of the bed's quality in patellar tendon compared with MRI. And with a new device of ultrasound, we can see all of the details of these tendinopathies, as well as the neovascularization scale, in which grade 0 doesn't show flows. In the grade 1, vascular flow is visible only near the tendon. Grade 2 is the presence of 1 or 2 vessels in the patellar tendon, and the much higher grade is the 3, the presence of 3 or more vessels in the patellar tendon, like this video. But the MRI is used only for chronic cases, localization with a greater precision, identification of concomitant injuries, does not serve as a prognosis. There are not immediate changes with any treatment. But what can be done? The first stage is a non-invasive treatment like physiotherapy or minimal invasive treatment. In this stage, enter the biological treatments, or in some complicated cases, a surgical treatment. There are many reviews on possible treatments in tendinopathy, such as biophysical stimulation, bioactive agents, cell therapy, scaffold implantations, or surgical approaches to tendon injuries. Therefore, the rehabilitation is a cornerstone of 3 phases of treatment. In stage 1, the pain modulation and the load management. The stage 2, strengthening, exercise, and load progression. And the stage 3, the functional strengthening and return to sport. The best current therapeutic alternative is the use of shock waves. And there is important to say there is no major difference in the therapy with radial pressure waves and the focal shock waves in different studies. The way we apply shock waves is with the patient in supine position with the knee flexed. In this review, the authors recommend the use of shock waves in chronic tendinopathy or when the conservative treatments have failed. Use of anesthesia is not recommended. It should be kept at least 2 weeks at relative rates after shock waves. Working with eccentric exercise shows better results than with just shock waves alone. 3 to 5 sessions, 1 per week, are necessary to achieve a complete treatment. And this is the suggested protocol for shock wave types, the radial shock waves and focused shock waves. This was, or the shock waves, demonstrated in this meta-analysis by Liao, which concludes this study obtains a moderate evidence that general shock waves significantly increase treatment success rate, reduce pain, and improves functional recovery in patients with knee tendinopathy. Based on meta-analysis, both shock waves therapies are worth considering in the treatment of soft tissue disorders, particularly in this patellar tendinopathy. But be careful. We have started to have complications due to poor application and ignorance of this technology in case of chronic tendinopathies, where it is observed like this case. Tendon tears and difficult in their resolutions. Therefore, we recommend reading of this review article, which was on OnLab before, detailing the complications and poor results with shock waves. We had worked together or after the application of shock waves with a high volume image guide injection, which has been shown to be complementary method to improve the function and pathology of chronic patellar tendinopathies. Some examples of this technique, the objective of this technique is to dissect the space between the tendon and the space between the tendon and the HOFA fat, eliminated the pathological blood vessels. With more flow of fluid, we can cut the pathological blood vessels. But there are several effective alternatives for these pathologies, such as open and arthroscopic surgical treatments, medication, high-intensity laser, and also biological treatments with a PRP or stem cells. The success is achieved with an accurate knowledge of the pathology, proper use of technique, ultrasound guide in the modes treatment, and the most important is a teamwork. Thank you very much for your attention.